Hello, my dear doctors. So today I'm going to talk a bit about the consultation station, and topic I have chosen today is Cushing syndrome, and this is quite common topic, and it's a high probability that you came across this case in your consultation station. So as you know, in the consultation station, it's a new station, and it's called now the PACE is called PACE 23. It's going to be implemented by end of this year, and it is a 20-minute station. In the first 15 minutes, you have to take the history, do the relevant physical examination, uh, answer any queries raised by the patient, and the final 5 minutes are for the examiner to ask some questions. So let's talk about the Cushing syndrome. So I've taken this case for you. So this is a 35-year-old female, and she presents with increasing weight gain over 6 months, which is not in keeping with her diet and activity level. Her weight has suddenly increased, and she now has significant abdominal obesity, as well as increased weight around the face, neck, and upper back. She also reports irregularity in her menstrual cycle over the last 4 months, and also she has noticed increasing central lower back pain over the past month, although denies any history of falls or trauma and has no complicating sensory changes in her lower limbs or incontinence. She remains active with gentle walking, however, she noticed difficulty getting out of chairs in the last few months. So, if you just concentrate on the buzzwords which I've highlighted in the red, then these are the important points which you must ask in your history. Menstrual history is very important. So, as you know that there can be some irregularities in the menstrual cycle because of the hormonal imbalance. Central lower back pain. Ask about any pain because with the Cushing syndrome, there's a chance of osteoporosis and sometimes may have a fracture at the compression fractures or anything. And you should ask about the daily activities like if they have any difficulty getting out of chairs or combing hairs or anything. So these all indicates proximal myopathy. So continuing our history, she reports recent difficulties with anxiety and irritability. Of note, she has no history of headache nor vision changes. So remember that any endocrine or the chronic problems, patient may have some anxiety or irritability. You must ask about that one. This is important to ask about the headache or any vision changes, as you know that if you're talking about the Cushing syndrome, Cushing disease, then the likely cause is there may be some tumor in the pituitary, or normally it is microadenoma, but sometimes microadenoma it can be a large tumor and can compress on the optic chiasm, so it can cause some vision changes. Specifically, we're talking about the bitemporal hemianopia. However, the other nerves also can be involved, because it can invade the cavernous sinus. So, fifth nerve, seventh nerve, eighth nerve, other nerves, carrying nerves can also be involved. She does not have any concern of hirsutism or acne. So, hirsutism or acne means androgen excess. Normally, with the Cushing's, females don't have this androgen excess. Um, in the males, the androgen excess, the patient can present with decreased libido and may have erectile dysfunctions. So she has been well recently with no history of infection. So must ask about any past history, any infections as well. She has no known medical history, in particular no previous history of hypertension or any diabetes. These are the important things because sometimes patient can have the symptoms of the diabetes, and once you dig it, then you may found that patient may have a polyuria, polydipsia, may have some weight loss or something. And she is not on regular medicines and denies any exogenous steroid use. This is a very important point, and must ask the patient if you're suspecting Cushing's disease, Cushing syndrome, sorry, as we're thinking about the iatrogenic causes. So must ask about any use of steroid. She is a non-smoker and has no family history of lung cancer. This point is also important because We know that small cell carcinoma can produce ACTH and patient can present with the Cushing syndrome. So must ask about the smoking history and a family history of lung cancer. She drinks alcohol occasionally, denies low mood or history of depression, and denies any current pregnancy. So these are the important things, especially females. We ask about the previous pregnancy. Alcohol history should be taken in all the patients. Then we move on to the examination. So on the examination, the patient does not appear unwell. Patient is okay. Blood pressure is 145/90. Maybe you can check the blood pressure if you have the BP test available. Otherwise, you can ask the examiner about the blood pressure. On general appearance, she is obese, BMI of 32. BMI you cannot calculate, but just I have mentioned it. Specifically in the general examination, we want to look for the distribution of the obesity. So obesity is central, involving the abdomen, trunk, and neck. And there is increased fat distribution over her upper back, causing a harm. Across her abdomen and thighs, there are white purple striae. So if there's any abdominal distribution of fat, must mention it, and obviously looking for any striae there. She has a round face with characteristic moon face and plethora. So the face may be because of the deposition of the adipose tissue may appear round. Her upper limbs and lower limbs reveals many ecchymosis. However, she denies any associated trauma. There may be some ecchymosis and without any trauma, or when even patient will say with minor trauma they have this ecchymosis, and this happens because of the thin skin, because of the increased glucocorticoids. She has no hysterism or acne and has no areas of hyperpigmentation. Then we go do the visual examination, and this is unremarkable, and of note she has no abnormalities of ocular movements, there is no diplopia, there is no papilloedema, and there is no visual field defect. Okay, upper and lower limb neurological examination reveals proximal myopathy. So must look for the power, and you notice that there is decreased power proximally. She is unable to raise from a chair without using her arms or for support. Otherwise, the neurological examination is unremarkable. On examination of her back, she has point tenderness over L1 vertebra. No other point tenderness occurs on palpation. So it's a good idea that if you're suspecting somebody with Cushing syndrome, just palpate the spine to look for any tenderness there, as these patients are prone for the fractures of the vertebra. And there's no hip irritability or pain on testing hip movement. If the patient say got some pain in the hip, or there's some problem with the walking, then it's a good idea to just do briefly hip examination. Just do some movements like internal rotation, external rotation, and look for any pain there or any restriction of the movement. Why this is important? Because some patients, they may have avascular necrosis of the femoral neck, and which can cause a minor fracture, may get unnoticed. Normally it happens because of the increased glucocorticoids, and it can happen in Cushing syndrome. Examination of the other organ system is unremarkable. So that's all about the examination. How we will investigate the patient? So in the context of the patient history and examination being suspicious for Cushing syndrome, there is no evidence of exogenous glucocorticoid use. So patient undergo 24-hour urinary cortisol excretion and a late night salivary cortisol test. These are both abnormally elevated, and both investigations are repeated, and the results remain abnormal. So remember that we can do 3 tests actually. Either we can do 24-hour urinary cortisol, we can do the low dose dexamethasone suppression test, and we can also do the late night salivary cortisol test. So in order to get the diagnosis of the Cushing syndrome, we need at least 2 of these 3 positive, and on repeat test also should be positive. So with biochemical hypercortisolism shown on initial investigation, the patient then has further investigations to determine the cause of the hypercortisolism. She had a plasma ACTH level which is elevated above the reference range. So once you have confirmed that the patient has a Cushing syndrome, we now want to know the cause. So the ACTH level is very important, because we want to know whether the patient has ACTH dependent or ACTH independent Cushing syndrome. Obviously, if it is an ACTH dependent, the ACTH level is high, then we're thinking about the Cushing disease. So she then has, so once the ACTH level is high, okay, then the next step is you want to know what is the cause of the high ACTH. So for that one, you have to do the high dose dexamethasone suppression test, which is done in this patient, and it was done with the dexamethasone infusion protocol. You can do the dexamethasone, high dose dexamethasone by giving orally dexamethasone or by the IV. So at 4 hours post the infusion, her plasma cortisol is mildly suppressed at 25% of the reference range. The plasma cortisol level on testing the following morning has returned to baseline and is no longer suppressed. So there is some suppression of the cortisol level once you do the high dose dexamethasone suppression test. Then it means this is an ACTH dependent. ACT, if there is a it's not, the ACT is not from the pituitary, then there will be no suppression with the high dose dexamethasone suppression test like ectopic ACTH secretion. The cortisol level will not be suppressed with the high dose dexamethasone. A pituitary MRI is performed and noted a 7 mm pituitary lesion is identified in it. So once you have done all these, remember in endocrinology, first we must confirm the diagnosis by doing the suppression tests, or in some cases the stimulation tests, and then we go on to the imaging. Why it is important is we should not do the MRI imaging on the first step, because there is a high incidence of something called incidental findings or incidental tomas. So we want to avoid that one. In addition to this, we like to do the patient fasting blood glucose, and this was 4.2, hemoglobin A1C was 5%. Fasting cholesterol levels reveals LDL was 5, HDL 0.8, and TGL level 3. So important, the patient, once you have done all this, then you have to do some additional investigations. We want to know the patient glucose and the cholesterol level as well. In addition to this, as we mentioned in the history, the patient has some tenderness at the lumbar spine. So she also go through the imaging of a lumbar spine, X-ray, and then CT. However, it does not show any evidence of compression fracture. So coming to the management, the diagnosis of Cushing disease and the need for neurosurgery opinion for operative management is discussed with the patient. And you know, if the patient has Cushing disease, the best option is to go for the surgery. So in addition, the patient was also commenced on perindopril for hypertension and atorvastatin for dyslipidemia, and we obviously on follow-up we plan to titrate the medication as required. Her vaccination schedule is reviewed and it is confirmed that she has previously received all age-appropriate vaccination. So she is also given the influenza, herpes zoster, and pneumococcal vaccination. Now, in discussion with the patient, her general practitioner, endocrinologist, and neurosurgeon, decision is made for a transvenoidal selective adenomectomy with the necessary medical perioperative input. So we need the multidisciplinary team. We should involve the patient. We need the endocrinologist and neurosurgeon, and then we should give all the options to the patient and let the patient decide what they want, how they want to proceed further. Potential complications of procedures, they are discussed with the patient, and she was informed of the post-op monitoring required to assist in identifying these issues if they arise. So, there are a lot of complications can happen if you're doing the surgery. Most important is pan-hypopituitarism. So the patient must be aware of that one, and we have to follow up with the hormonal level post-op to check whether the patient has any pan-hypopituitarism or everything is going well. So post-op glucocorticoid replacement is discussed, and the patient is informed there is significant recurrence rate of Cushing disease, and she may need further medical or surgical treatment or radiotherapy after her initial surgery in order to achieve remission if the procedure is not successful or there is a recurrence in the future. So patient has to be counseled that there is a chance that there might be recurrence, so there may be additional treatment needed, maybe going for surgery again, or sometimes just the radiotherapy. And in the long term, the patient is aware that a large focus of our management will be on her cardiovascular health. So mainly we'll be focusing on obviously the cardiovascular health is very important as we mentioned, we want to control the blood pressure, we want to control any dyslipidemias with the statins. So this is all about the management. I hope I try to be very brief and to the point. It will help you. But again, whatever sources you are reading, just go through it. And this my presentation just food for thoughts. So um, hopefully it is helpful to you, and I'll see you in my next presentation. Thank you very much.